It's Friday morning. You're the rural GP on call. A 70-year-old farmer is brought into your ED. Sudden right-sided weakness, slurred speech. His CT shows a large established infarct. Aspect score of 3. Most of the MCA territory is already dark.
And the question that runs through your mind is one of the most contentious in stroke medicine. Do you transfer him for thrombectomy? The infarct is large. The traditional teaching was that thrombectomy only works for small to medium core infarcts. Large core meant the tissue was already dead.
Good morning. It's Friday, August the 7th. 4 stories today, and the first one changes how we think about exactly that scenario. Story 1. The Tesla trial. 1-year follow-up, published this week in JAMA. Thrombectomy for large core ischemic stroke.
The original Tesla results were presented last year and caused a stir. 300 patients across 47 U.S. stroke centers all had large anterior circulation infarcts identified on plain non-contrast CT. Aspect scores of 2 to 5. These are the patients we've historically told families there's nothing we can do.
At 90 days, the primary endpoint narrowly missed statistical superiority. The Bayesian probability of benefit was 95.7%, just short of the 97.5% threshold. Many people wrote it off as a negative trial.
But the investigators had pre-specified 1-year outcomes, and this is where it gets genuinely practice-changing. At 1 year, functional independence, meaning modified Rankin scale 0 to 2, was achieved by 24% of the thrombectomy group versus 7% of medical management alone.
That's more than 3 times as many patients living independently. Independent ambulation, Rankin 0 to 3, was 35% versus 18%. Quality of life scores were significantly higher, and mortality was similar between groups at 43 versus 47%.
Let me be clear about what this means. In a population with devastating strokes where the natural history is grim, thrombectomy tripled the chance of functional independence. 1 in 4 thrombectomy patients was living independently at a year, compared to 1 in 15 with medical management alone.
And the selection used plain CT, not perfusion imaging, not MRI, just the non-contrast CT that every rural hospital already has. That's the key. It lowers the barrier. You don't need a specialized imaging protocol to identify candidates.
The catch is that these are exploratory outcomes from a trial that missed its primary endpoint. The 1-year analysis was pre-specified, which helps, but it's a research letter, not a full article, and the hemorrhage rates were higher with thrombectomy. Symptomatic intracranial hemorrhage was 4% versus 1%.
But here's the clinical bottom line. We already have Select Rescue Japan Limit, Angel Aspect, and Last showing benefit for large core thrombectomy. Tesla extends that to the CT-only selection paradigm. The totality of evidence now supports considering thrombectomy for large core infarcts, especially when selected by aspects on plain CT.
For the rural GP anaesthetist, this means something concrete. When that farmer walks through your ED door with a devastating CT, the decision to transfer for thrombectomy is now supported by evidence. Don't rule it out just because the core looks large. The window is 24 hours. Call the stroke team.
Story 2. And this one's for your mental health patients. Psilocybin-assisted therapy for treatment-resistant depression in an NHS public healthcare setting, published this week in Nature Medicine.
Let me set the scene. You have a patient in their 40s, 2 failed antidepressant trials. They've tried SSRIs, they've tried SNRIs. Nothing has worked, they're functionally impaired. And you're running out of options. Ketamine works but is temporary. ECT works but carries stigma and cognitive effects.
This trial was conducted at the South London and Maudsley NHS Foundation Trust. 60 participants with treatment-resistant depression, meaning they'd failed at least 2 antidepressant treatments. Double-blind, randomized, placebo-controlled. 25 milligrams of synthetic psilocybin versus placebo, with psychological preparation, dosing support, and integration sessions.
The primary outcome was feasibility, but the efficacy signal was remarkable. At week 3, the between-group difference on the Montgomery-Åsberg depression rating scale was minus 10.4 points. Cohen's d of 1.7. That is an enormous effect size for psychiatry.
For context, a typical antidepressant effect size is around 0.3. This is 5 times that, and the benefit was sustained at 6 weeks.
But I need to be honest about the limitations. 60 patients is small. The follow-up is only 6 weeks, and functional blinding is a real problem. Anyone who takes 25 milligrams of psilocybin knows they've taken it. The psychedelic experience is unmistakable, so expectancy effects could inflate the results.
That's been the central critique of the entire psilocybin literature. The Goodwin trial in NEM, the Episode trial in JAMA Psychiatry, both showed large effects but faced the same blinding problem. Episode was actually negative on its primary endpoint, though it showed secondary signal.
What makes this NHS trial different is the setting. This wasn't a specialized psychedelic research center. This was routine NHS mental health infrastructure. The authors showed that psilocybin-assisted therapy can be delivered in a public healthcare system with good retention, good safety, and a strong efficacy signal.
Safety is critical. Adverse events were mostly mild. No change in suicidality or mania scores. Serious adverse events were deemed unrelated to treatment. This matters because earlier psilocybin trials had signals for suicidal ideation on dosing days.
Where does this leave the clinician? Psilocybin is not available in clinical practice. It's not TGA approved. But this trial, combined with the broader literature, supports the ongoing Phase 3 program. If those trials replicate this signal, psilocybin-assisted therapy could become a genuine option for treatment-resistant depression within 2 to 3 years.
For now, it tells you that this approach is real, not hype. When patients ask about psychedelics, and they will, you can say the evidence is strengthening but it's not ready for clinical use. Ketamine and esketamine remain the only rapidly acting options available now. Story 3. And this one's about breast cancer screening. Something every GP discusses every day. The JSTART trial. Long-term results published in The Lancet earlier this year, but the implications are still being digested.
The question is simple. Should we be adding ultrasound to mammography for women with dense breast tissue? We know mammography misses cancers in dense breasts. The sensitivity drops dramatically, and Asian women, on average, have denser breast tissue than Caucasian women.
JSTOT is the Japan Strategic Anti-Cancer Randomized Trial. 72,661 women aged 40 to 49, randomized to mammography plus ultrasound or mammography alone, 2 screening rounds over 2 years, and now we have 11-year follow-up.
The primary outcome was detection rates and sensitivity in the original publication, but the long-term secondary analysis is what matters clinically. Did finding more cancers actually reduce the incidence of advanced breast cancer? Because detection without mortality benefit is just overdiagnosis.
The answer is yes. Among cancers detected, 26% were advanced, stage 2 or higher, in the ultrasound group, versus 33% in the mammography-only group. Hazard ratio of 0.83, statistically significant.
Let me translate that. Adding ultrasound shifted the stage distribution toward earlier cancers, fewer stage 3 and 4 disease, and the Kaplan-Meier curves showed the benefit emerging around year 4, widening through year 8, then stabilizing. That temporal pattern is consistent with a true screening benefit, not a lead time artifact.
The specificity trade-off is real. Ultrasound finds more false positives, more biopsies, more anxiety. In the original JSTART report, specificity dropped from 91% to 88%. That's about 3 additional false positives per 100 women screened.
For an Australian GP, the direct application is limited because BreastScreen Australia doesn't currently offer supplemental ultrasound. But this evidence is relevant for 2 groups: women with dense breasts on mammography who ask about supplemental screening, and women in the 40 to 49 age group where mammography sensitivity is lowest.
And the relevance extends beyond Asian populations. Dense breast tissue is common across all ethnicities. About 40% of women aged 40 to 49 have dense breasts. The JSTART data supports the case for supplemental ultrasound in this group, especially when mammography is known to be less sensitive.
Bottom line for practice: when a patient asks whether her dense breasts need more than mammography, you now have randomized trial evidence that supplemental ultrasound reduces advanced cancer. It's not standard of care in Australia yet, but it's a reasonable discussion, and the evidence base is growing.
Story 4. Continuous glucose monitoring initiated in primary care. Published in JAMA Network Open last month. 8,502 adults with insulin-treated diabetes across 18 primary care clinics in the Bronx.
This is important because most diabetes care happens in primary care, not endocrinology, and CGM has been proven in specialist settings, but we haven't had good data on what happens when primary care doctors prescribe it.
28% of patients were prescribed CGM by their primary care clinician. At 12 months, HbA1c dropped by 0.66 percentage points in the CGM group versus 0.17 in the non-CGM group, a between-group difference of nearly half a percentage point.
Half a percentage point of HbA1c is clinically meaningful. For context, adding a second oral agent typically gives you about that much, and this came from a device, not a drug. Fewer side effects, no hypoglycemia risk from the intervention itself.
But the harder endpoints matter more. CGM initiation was associated with a 13% reduction in recurrent hospitalizations and an 18% reduction in ED visits, in a safety net population with high baseline utilization.
This is observational data, not randomized. Patients who were prescribed CGM were younger, more likely English-speaking, and had higher baseline HbA1c. Confounding by indication is a real concern. Sicker patients might be more likely to get CGM, which could bias toward the null, not toward benefit.
Fair point. But the consistency across outcomes, HbA1c, hospitalizations, ED visits, makes a strong case, and this is a safety net population in the Bronx. These are underserved patients with complex social determinants. If CGM works here, it works broadly.
For Australian practice, CGM is already subsidized for type 1 diabetes and for concession card holders with type 1. Expanding access to insulin-treated type 2 diabetes in primary care is the next frontier. This study provides the evidence base for that expansion.
Quick hits before we wrap up. PBS brand changes from September the 1st. Amoxil capsules, Cardizem CD, Actos and Polyvisc are being removed. Check your patient's prescriptions and transition them to remaining generic brands. This is routine housekeeping but worth a note in your practice system.
And a reminder on the ANZCA GLP-1 guidance. Updated last month, do not stop GLP-1 receptor agonists before procedures. Continue them and use a 24-hour clear fluid diet pre-procedurally. This is now settled guidance, consistent across ANZCA, ISHE, ADS, and international bodies.
Let's recap. 4 stories today. 1. TSLA 1-year follow-up. Thrombectomy for large core stroke selected by plain CT triples functional independence at 1 year. Don't rule out transfer just because the infarct looks large.
2. Psilocybin for treatment-resistant depression in the NHS. Effect size of 1.7, but small sample, short follow-up, and blinding limitations. Phase 3 trials ongoing, not ready for clinical use yet.
3. JSTART long-term follow-up. Supplemental ultrasound for women aged 40 to 49 reduces advanced breast cancer. First randomized evidence for ultrasound in screening. Discuss with patients who have dense breasts.
4. Primary care CGM. Nearly half a percentage point HbA1c reduction, plus fewer hospitalizations and ED visits when primary care doctors initiate CGM in insulin-treated diabetes. Evidence for expanding access.
That's it for today. See you on Monday. Stay sharp.